And Dr. Hota, can you please tell somebody to record these proceedings?
See, we have connected to YouTube now also. We'll record it also.
Okay, fine. So I'm not recording from your side, no problem.
We are recording it.
Yes, fine.
Now it is live in the YouTube also.
Perfectly all right. So whenever you say, we will go live.
Now it is already live in YouTube also.
No. I mean, we'll commence the.
We'll start exactly at 4, another 5 minutes. Any preparation if you want to have, you can go ahead also. Because we are 6 minutes before 4 o'clock. Yeah. See, এটা কাই রেজিস্টার কাম করতে না দিছো বড়টা না বড়টা স্যার ভিসে আইপি বেস যেটা ডেফিনিশন সেটা এইটা সেন্টার প্রোগ্রাম হলে আইপি বেস এটা সফটওয়্যার সেটা হচ্ছে Kandar, what is the time that you are going to utilize? 2 hours?
Yeah, maximum.
Maximum, right. And I think if in that case, if you can finish up within 1.5 hours, then you can keep the last half hour for.
Yeah, maybe little early I'll finish.
Yeah,
maybe little early I'll finish.
Yeah. So that the participant can clarify the doubts.
Of course, and I think I have tried to cover many questions which are generally asked during the workshops. So I think probably they won't have anything to ask actually after I finish my talk. That's what I believe, especially for the basics in RIRS. I'm not talking about advanced RIRS, but basics RIRS. I think I have covered majority of the things. Probably I'm going little more in deep than my usual classes I take. But I think because there are many postgraduates who are attending this, likely to attend this program. So I thought that because they are like a blank paper, so whatever you write, it will be very clear and crisp. So I think probably for them to understand from the beginning will make a lot of difference in understanding of RIRS.
Most of our residents have come here to this telemedicine center. Most of the students, very few are logging in from outside.
Yeah.
So I think as we proceed, we will be looking at the chat box. I'll tell about the procedure, how to ask a question. If somebody has a question, he will just put in the chat box. At the end of your talk, we will find out the chat box and one after the other we can go ahead. Is it okay, Kandar?
Perfectly all right. Perfectly all right. Your voice is not very much audible.
My voice? Is it okay now? Just a minute, I'm just improving it. Hello, Kandar, is it better?
I think there was some noise. There is some background. There is some kind of a background. Now it is okay.
No, the AC is going on. That may be the reason.
Okay.
AC is very nearby.
But my audio is proper, right? You can hear me properly, nicely, because this is what people are going to listen. So is it perfect?
Perfect. It is perfect.
Okay, perfectly.
There is no problem in your audio.
Come again?
There is no problem in your audio.
Thank you. Yes.
In a couple of minutes, exactly 2 minutes afterward, you are starting.
Yes, please. You just tell me whenever I have to start. Just introduce a little bit about your concept, and then I think we can start.
Do you need to be introduced?
No, not me. Your concept for this kind of a program, and whatever is in your mind.
Yeah. Yes, sir. Sure. Urology Academic Forum.
पार्टिसिपेंट का नाम देखाई बसे सर
अच्छा
एडम डिपार्टमेंट ऑफ यूरोलॉजी
ऐसे भी
तो नाम यूरोलॉजी আছে
SCBMC. Good evening, everybody. In fact, it is an evening with Dr. Kandar Parikh. He is not only a stalwart in neurology in the country, but what is much more important that his acumen in RIRS is unparalleled and unmatched. Now, few days back, I had requested Dr. Parikh to interact among all the residents regarding RIRS, and he happily agreed. I am thankful to him. Then it was a suggestion that since he is going to give a talk, let everybody benefit from his talk. Today, as you know, RIRS has developed like anything, what he is going to talk in due course of time. But most importantly, what was unthinkable before, that a kidney stone can have an access to the retrograde method, and the stone clearance can be very good, despite the fact that you have to traverse such a distance from the meatus to the calyces. Still, it has become possible, feasible, and also successful. Now, all the residents have a lot of interest to know about RIRS. In many centers like mine, you know, we do RIRS very infrequently, maybe because we are inclined more towards the PCNL. That may be the reason. But after this talk, I think my residents and my faculty who are present with me will definitely get encouraged to do more of RIRS and less of PCNL, the trick and tips what our Dr. Parikh is going to provide today. Now, with these few words, I request Dr. Parikh to continue or start his proceedings. As regard the planning we have, you know, once whoever has a query during his talk, not to interrupt him, he can send in the chat box his questions, which we will see here. At the end of his talk, we will definitely bring those questions for discussion, and the person who has given those questions, he will come online and he can interact with Dr. Parikh directly. So with these words, I request Dr. Parikh to take over the platform.
All right. So good evening, namaskar. And at the outset, I thank Dr. Hota and Urology Forum of Odisha for giving me this lovely opportunity to interact with mainly the PGs and some of the senior consultants joining us from all across the world. In next few hours, I'm going to cover what you need to know about RIRS, especially when you are initiating RIRS program in your institute, as well as those who are doing RIRS regularly. They will have a quick revision. I'll also provide some of the tips and the tricks of RIRS. So while you are performing a procedure, it will certainly help you. As we all know, the treatment of renal stone is based on 4 important pillars. ESWL, of course, it is a non-invasive method. but the modality is not now very routinely utilized all across the world because of many reasons, mainly the limitations of the size of the stone and morbidity problems related to the procedure. PCNL is practiced all across the world for almost all size of the renal stone, but now it is limited for
Hello, Kandar. Hello. Unmute yourself. Unmute yourself. Unmute yourself.
Okay, so I start from the beginning of.
No, it's okay. We are hearing you. You can go ahead.
Okay, so as I said, the treatment of renal stone is based on 4 important pillars. ESWL, though non-invasive, though opted by many of us in the past, is now not routinely practiced because of the limitations related to ESWL. PCNL practiced all across the world for almost all size of the stone, but now it is limited for the stone more than 3 centimeter in size. So when you have a stone which is less than 3 centimeter in size, right now in India and in adjoining countries, mini PCNL is routinely practiced. But in the Western world, in Europe, in United States, and in many parts of India now, RIRS is picking up because of its minimal invasive nature. It has got all the advantages of minimal invasive surgery. And also there is a patient preference and a surgeon's liking towards this procedure. In 1964, Marshall first reported use of fiber optic scope for the diagnosis of the ureteric stone. The fiber optic scope his colleagues used was having no deflection, so it was only as a diagnostic tool. Lot of credit goes to Dr. Begley, Dr. Michael Grasso for their immense research work for making this procedure most popular all across the world in the early 1980s. But a lot of credit goes to my friend, my philosopher, my guide, and my mentor, Dr. Olivier Trexler, who has popularized this technique all across the world, and his teachings have prepared many of us in the field of RIRS. So I express my deep gratitude to all these 3 gentlemen with whom I had an opportunity to share a common platform in many of the international workshops now. Now, if you look at EAU and AUA guidelines, because in our practice, we always follow EAU as well as AUA guidelines. Unfortunately, in India, we don't have guidelines for the stones. So the recent guidelines suggest that when the stone is less than 2 centimeter in size, that time RIRS should be preferred now over PCNL, especially when the stone is in the upper calyx and the middle calyx. If the stone is in the lower calyx, still mini PCNL can be performed if the size of the stone is even less than 2 centimeter in size. In United States, there is more inclination towards either ESWL or ureteroscopy for the stone less than 2 centimeters in size. In the guidelines, there are some flaws. Like guidelines are never constant because they review the literature and it keeps on changing as the technology advances, as the experience increases. So maybe in the new guideline by EAU and AU in next coming years, probably RIRS will be mentioned as a procedure of choice for the stone at least up to 3 centimeter in size. Other problem with the guideline is that there is no specific recommendation for a specific situations like a stone in a horseshoe kidney or ectopic kidney or a solitary kidney, what to do. Because then the treatment modal option may change considering the condition of the kidney as well as the patient. Now, when you offer a medical treatment to any patients, either ESWL, PCNL or RIRS, you have to look into consideration of certain factors like a stone burden and location. Mainly in many parts of the world, still only the stone size is seen as a marker. But as we all know that all 2 centimeter size stones are not equal. 2 by 2 by 2 centimeter size stone has a larger stone burden as compared to 2 by 1 by 0.7 centimeter stone. So one must consider stone burden as a marker for deciding a treatment, because the treatment may differ in every patient. The treatment you suggest should have good effect and produce a stone-free status for the patient, because that's what patient has come to you for. RIRS produces almost equivalent result as compared to mini PCNL as stone-free status is concerned now. RIRS certainly has less complications and minimum morbidity. There is hardly any mortality related to this procedure. And that's the reason patient accept it. In today's time, patients' preference should be given consideration in the decision making of the surgery. Now coming to the surgeon's preference, surgeon's expertise, surgeon's experience, and surgeon's ease of comfort performing a procedure makes a lot of difference in deciding the therapy for the patient. With RIRS, most of the surgeons are also at comfort, and the procedure you recommend should be reproducible. Because today we are taking this course for the PGs. Now they should also be in a position to perform this operative modality with lot of comfort after experience of 20-30 cases of RIRS. And I think it is easy to learn if you are taught properly. And lastly, whatever therapy we suggest should be supported by the literature, because we are practicing in the era of evidence-based surgery. So after Marshall reported the first case of fiber optics in urology, after the basic research by Dr. Begley and his friends, his colleagues, 1980s, there was incorporation of accessory channel in the flexible ureteroscope that converted this passive diagnostic tool into a therapeutic tool. But the real game changer was holmium egg laser in the year 1993. It was Johansson who reported the use of holmium egg laser for the intracorporeal lithotripsy, and after that this procedure became very popular, especially in United States. The first generation ureteroscopes were very large in caliber. They were 10 French in diameter, and the deflection was only in one direction, and that was 180 degrees. And most of the ureteroscope lasted for somewhere between 5 to 16 cases, and then they required replacement or repair. I remember that I attended AUA meeting in year 2002, and I attended my first course on RIRS. We were extremely impressed with the modality, but when the course got over, we were all depressed because we thought that this modality cannot come to India. And as Dr. Hota correctly said, that many of us are doing mini PCNL in India because of the consideration of finance. Now, last 2 decades have changed so much. And what has changed? So the diameter of the scope has changed from 10 French. Now it has come down to 7.5 French. The deflection is improved from 180 degree on one side to 270 degree on both the sides. Because of the technological innovations and improvement, the image quality has also significantly improved. And from the era of fiber optic scope, we have ventured into the digital scopes. Durability was initially a problem, but now most of the ureteroscopes, especially the fiber optic ureteroscopes, last for minimum to 50 to 70 cases. And there was a wonderful study carried out by Dr. Trexler and his group, and they studied all the possible flexible scopes in the market, and they declared that most of the scopes last for more than 50 cases, and FlexX 2S lasted little more. So basically, we have now 3 scopes three type of scopes: flexible scopes with the fiber optics, the digital scopes, and now a disposable scopes. So this is my armamentarium. We have in my hospital FlexX 2S from Karl Storz, that's a fiber optic scope. FlexX C from Karl Storz, that is a digital scope. BOA and Cobra Vision from Richard Wolf, both are digital scope, and this is LithoView, this is disposable scope. Now let's have a close view of fiber optic flexible scope. This is FlexX 2S from Karl Storz. It has got three parts: the tip, the shaft, and the handle. The tip of every company is slightly different. The shaft is a stiff shaft, and in the handle, there are three important parts. One is a deflection lever, which is responsible for bending the 270-degree deflection on either side. This is a connector for the light cable, and this is optical lens where you can attach your camera. It is important to know your scope so that you can maintain it good, because the durability of the scope is always a problem, and finance is a major consideration, especially in a government institute where you have to offer these services. So if you know exactly your instrument, you will know how to maintain it, and then the durability will certainly increase. So you can open up this scope from the junction of the handle and the shaft. So this is an opened scope. This is the part of the shaft, and it has got 5 components. There are these thread-like structures, 2 structures what you see. One is an image bundle and another is a light bundle. The image bundle carries image and the light bundle carries the light. There is this straw-like structure, what you see here. If you have a closer look, this is a accessory channel. And these 2 wires are responsible, these are the control wires, these are responsible for the deflection of the scope coming from the tip of the scope, going right up to the handle. Here, these 2 wires have an adapter here, and this is an opened up handle. Here you can see there are 2 wires with the adapters here. And if you open the handle, you can see a pulley-like structure. So these 2 wires will run over this pulley. And finally, you can attach the wires coming from the shaft to the wires coming from the handle. So in a way, it becomes only 1 wire. So when you produce a deflection like this, you can see there is a movement of the wire. So if you pull this wire is retracted. So that's how the deflection is produced. So why this is important for you to know this? Because whenever you are working in a lower calyx, you produce extreme deflection. Now, if you put a lot of pressure while operating, the wires will break either at the tip of the scope or they will break here. Even if you are using a scope for many times, this connection becomes loose. That's why from 270-degree deflection, now it will become a 180 or 220-degree deflection. Now, if you keep on working with this same scope, the deflection will gradually deteriorate, as well as for the lower calycial stone, you will tend to put a lot of pressure to reach to the stone, especially with the accessory inside the accessory channel. Then you will put a lot of pressure, and ultimately your scope, your deflection wires will break, and you will spend a lot of money for the repair. So my advice is that whenever the deflection is deteriorated from 270-degree to 220 or 180, do not use that scope. Please give it for the repair. They will simply open the handle and tighten these wires, and your scope is ready. So you will spend minimum money, and your scope is ready. Once you break this wire, they will ask you for the replacement. Okay, so let me give you one example. This was a very nice case reported where the scope was placed in the lower calyx. This was from the Dr. Manoj Monga and his group. And then there was a locking of the deflection, and the scope got fractured. So it was not possible to produce a good deflection, to correct the deflection. And that's why they were in real soup. Now, how do you take out this scope? So they first inserted a guide wire through this and tried to straighten this, but it was not possible. And then they ultimately, with the cutter, they cut at the junction of the shaft and the handle, and then pass the ureter lecture sheet over this shaft and try to straighten the scope. That was not possible. So ultimately, they pulled the scope in a deflected position. They could bring it right up to the pelvic brim, and then further they could not go, and they were worried about the ureteric avulsion. So they ultimately they had to open up the patient, put a Gibson incision, and then they delivered the scope. So this is what also can happen when you are not careful, or if there is a manufacturing defect. So this is, I thought that this will be of great interest to you to know. Now let's come back to these fiber optic scopes. The fiber optic scopes, the fiber is made up of the molten glass, and the diameter of that fiber is 800 micron. And in that bundle, you saw that white colored thread-like structure. There are many fibers, right? And the purpose of this fiber is to carry the light from one end to another and image from one end to another. So this is the center of the fiber. This is the glass, and over that there is a cladding. This cladding has a different refractile index than the core glass. Okay, and this cladding does not transmit the light, and that's the reason when you actually operate, you will see a honeycomb appearance or a mesh-like appearance. It is also known as the insect eye appearance. So this is important for you to know that whenever you are using a fiber optic scope, the vision is not as crisp as compared to the digital scope because of the fibers, and then there is over the core there is a cladding which does not permit light to go in. If you are putting a lot of pressure on the handle, or if you are pushing the fiber optic scope with lot of pressure in the ureter, sometimes you will break these fibers, and ultimately you will get a vision like this. These all black spots are the broken fibers, and once the vision is deteriorated, the result will be deteriorated. So it is very, very important for you to know that to handle this instrument or this fiber optic scope very, very, very gently. This is just to give you an example of what kind of flexible fiber optic scopes are available in India at this moment. We've got a FlexX 2S from Karl Stoss, P7 from Olympus, and Cobra from Richard Wolf. FlexX 2S and P7 almost have got the same parameters and specifications, except that FlexX 2S, the tip has a laser light ceramic beak covering last 1.5 centimeter of accessory channel. This ceramic beak will prevent injury to the accessory channel if accidentally you fire a laser. So that's a very, very important feature of this scope. As P7 is like a ureteric catheter. The shaft is very, very stiff. So negotiating into the ureter or backloading it over the guide wire like a ureteric catheter is very easy with P7 as compared to FlexX 2. Also P7, the vision is excellent. With FlexX 2S, the vision is good, but it has got a better maneuverability in the kidney. Within the kidney, I find it much, much better to move my scope with the FlexX 2S. And secondly, it is much more durable. Here, because the shaft is very stiff, it is slightly more fragile. And once one fiber will break, many fibers will break in the second or third case. So my preference is FlexX 2S, but you can purchase anything you like because P7 has a vision which is unparalleled. Now for Cobra, the diameter is 9.9 French. So it's a very, very big scope. The reason, because it has got two accessory channel instead of one accessory channel. Normally, every scope has an accessory channel which has a diameter of 3.6 French. So it will accommodate instrument which is less than 3 French. Because from the accessory channel, you irrigate the system as well as you introduce any accessory. So you have to keep some space for the water to also to go in. So that's the reason your preference should be use a minimum diameter accessory instrument like a guide wire or a basket or a laser fiber. So that will allow little more amount of fluid to go in with minimum of the pressure. Cobra has got two channels. So this one channel is 3.6 French which is, and second is a 2.6 French. And also this scope as a laser shifter. So what you can do is, and that is fixed on at a 9 o'clock position over the 3.6 accessory channel. So you can pass a laser fiber through that laser fixture, a laser shifter, and then you can fix the fiber so that there is no accidental movement of the fiber while you are operating, because you are fixing that laser fiber, and you can advance or withdraw the laser tip by rotating a knob over it. I'll just show you what exactly I mean to say by this. Okay. So these are the three flexible fiber optic scopes available in India at this moment. I was just talking about this white ceramic tip, which is at the tip of the FlexX 2S. This is very protective for the laser induced injury. This is a tip of the P7. They call it a bullet tip. Here the tip, extreme tip diameter is 4.9 French. So they call it as the thinnest possible fiber optic scope tip. And this is 7.5 French. So we can call it as a 7.5 French tip only. This is a Cobra scope, where you can see there is a laser shifter here. And this laser shifter will help you to prevent accidental injury due to the laser slippage or withdrawal. Coming to the digital scope. Instead of analog signal, now they are the digital signal. Instead of the lens as well as the fiber optics, they use a sensor chip which is placed at the tip of the scope. That's why they are known as chip on tip scopes. There are two types of chips available. One is CCD chip. It is called as a coupled charge device, which is a much mature technology, more expensive, while another is a CMOS technology chip, which is also known as a complementary metal oxide semiconductor. It is a low-cost device. The vision is good, and most of the scopes use this CMOS chip. Just to give you an example again, this is FlexX C from Karl Storz. The features of the scopes are almost the tip, shaft, and the handle is almost the same, but there is a difference. You can see here, there is no connector on the handle for the light cable because there is an inbuilt LED here. Secondly, there is no camera attachment here, and there is a wire that is connected to a processor unit. You have to keep one thing in your mind: whenever you order a digital scope, you have to have a compatible processor. So in case of FlexX C from Karl Storz, you need to have Image 1 hub. In case of URF V3, that's a digital scope from Olympus, you need to have Visera Elite system. So you have to have a compatible processor also. You cannot simply order one digital scope and without a processor unit, right? These are the four flexible digital scopes available in India. FlexX C from Karl Storz, URF V3 from Olympus. Almost features are same in both. BOA is from Richard Wolf, and Cobra, instead of Cobra, now it is Cobra Vision from Richard Wolf. So you exactly know what all is available in India for you. Now there are two types of models available. This is also very important because when you order, you don't know about this. Most of the people do not know about this. One is the American model and other is a European model. In American model, when you deflect the tip down, the tip goes down. So down is down and up is up. When you deflect it up, the tip goes up. They call it as an intuitive model, or they call it as a logic model. Because logic says that when you deflect down, the tip should go down. So this is logical model or a intuitive model. An European model, when you deflect the tip down, the tip goes up, and when you deflect the tip up, like seen in this picture, the tip goes down. So Americans call this an anti-logic or counterintuitive model. But when you ask Europeans, they will say that this is our logic and this is our intuitive model. I asked this question to Dr. Trexler that why do you call this as a logic? Because they are using this European model. And he explained me beautifully. He said that ureteroscopy is an extension of a cystoscopy. So whenever you do cystoscopy, when you want to look up, what you do is that you bring your scope down. When you look down, when you want to look down, you bring your scope up. The same thing is followed here. That's why for them, this is logic. For them, this is intuitive. But Americans call this, and most of the people in India, they use this American model. But it all depends with what scope you are trained. It's like, it's very simple to operate this scope. So don't worry about it. Whatever way you are trained, you can use it. Just to give you a comparison of both the scopes. This is a FlexX C from Carlstor's. Look at the vision difference. The stone here and here. This is FlexX 2S. This is a fiber optic scope from Carlstor's. There is a significant difference in both the scope. There is almost 5 times magnification with the digital scope. The vision is very crisp. And once you start doing procedure with a video scope or a digital scope, you will not like to do with the flexible scope. So that's a fact. In my practice, majority of the patients, I use a video scope, the digital scope, but flexible scope also has its place, because many a times the question is asked, then should we buy only digital scope? The answer is no. If you have to have one scope, you have to have only a fiber optic scope. Why? Because it's cheaper to buy. Digital scopes are expensive. Secondly, the diameter of flexible scope is 7.5 French, while a digital scope, the smallest digital scope is 8.5 French. So it's slightly bigger in the diameter. That's why it will require 9.5 French by 11.5 French ureteral access sheet for a flexible scope, while in a digital scope, you need to have a little larger ureteral access sheet, so 10 by 12. The diameter of the Indian ureter is very, very small. That's why sometimes you find it very difficult to put a 10 French ureteral access sheet. That's why you need to have a fiber optic scope. As far as the life of the scope is concerned, usually the fiber optic scope lasts between 50 to 60 cases, while the digital scope in my hand lasts more than 70-80 cases. It has got slightly better longevity because there are no fibers in my fiber optics into it. That's the reason it lasts little longer. But when you want to work into a lower calyx, I think fiber optic scopes are much better as compared to digital scope, because digital scope as I said, that at the tip there is a sensor. That's why tip is there is a metallic part at the tip of the scope, which is very big as compared to fiber optic scope where there is no metallic part. That's why its deflection into the lower calyx is much better with the flexible scope as compared to the digital scope. And ergonomically now, because fiber optic scope has a connector for the light, connector for the camera, the assembly becomes little heavy as compared to a digital scope where there is no separate connection for the light cable, there is no camera attached. So ergonomically, it is easy to handle as compared to the fiber optic scope. Coming to the disposable flexible ureteroscope, the first ureteroscope which was introduced was a polyscope, but it never became very popular because the assembly was not good. It was very cumbersome to do the assembly of this scope. After that, there came a semi-rigid flexi tip ureteroscopes, where the shaft was stiff and only the tip could be deflected. But then it could not produce good results, so it is not probably used in many parts of the world. So the most popular disposable flexi ureteroscope, which is used across the world, is a LithoView from Boston. And now, one Chinese company, Hussein, they have also come out with the U scope that is also becoming more and more popular. We should be happy that in India, a BioRed company has come out with the Indoscope. It's an Indian-made scope. That's what they say. And it has also got a very good vision. So right now in India, we have got a LithoView, U-scope, and Invisio, which is a BioRed scope. The only difference is that LithoView has a diameter of 9.5. It's very big. Hussein is also 9 French. While BioRed, the current model is 9.5 French, but now they have come out with a 7.5 French scope, which is as good as the fiber optic flexible ureteroscope. So, and another difference between these scopes is that for the LithoView and U scope, you can use it only for 4.5 hours, and there is a locking device. While in case of BioRed, the scope lasts for 20 hours, and many of Indian colleagues are using one scope for many cases. Of course, it will kill the purpose of a disposable scope, but because of financial consideration, I call this scope as a limited use ureteroscope rather than calling it as a disposable ureteroscope. Disposable ureteroscope has certain advantages, like there is no possibility of a cross infection because you are all the time using a new scope. Second important thing is that it is cheaper to buy because one scope costs around 70 to 80,000 rupees, but it lasts only for one case if you use it for only one case. Another advantage is that it's always readily available. You don't have to sterilize it, you don't have to process it, so it is readily available. And the fourth advantage is that when you want to train your residents for the PGs, in that case, if you give them a disposable scope, and if they break it, you don't have a heavy loss. So it is good for the postgraduate training also. And in my practice, I use this disposable scope, especially when I deal with a larger stone bulk in a lower calyx or a complex pelvic alyssal system. I use a disposable scope. Otherwise, in most of the patients, I use a reusable, either a digital scope or fiber optic scope. Let me give you the idea about the vision, what you can see. Here is the P7 from Olympus. This is a fiber optic scope. You can look at the vision. This is FlexX C from Karl Storz. It has got a lovely vision, and I think I like it the most. This is LithoView from Boston. The vision is also good. This is a digital scope and a disposable scope, and this is U scope from Pusen. So among all scope, the vision with the digital scope is the best, but the cost only is a prohibiting factor. Now, we discussed about the accessory channel, which is 3.6 French in caliber. So from the accessory channel, you can introduce water as well as you can introduce accessory, whatever accessories like a basket or a laser fiber. When the accessory channel is empty, you can produce a 270-degree deflection like this. You can see it here. This 270-degree deflection. But the moment you put a laser fiber into it, you put a 200 micron laser fiber, now the deflection is slightly reduced. There is a 20-degree compromise in the deflection. So from 270, it has gone to 250, but that's not bad. You can still reach to any lower calyxal stone with this position. You can see a small laser fiber coming out through that deflected tip of the scope. This is 200 micron. When you put a 265 micron fiber, you can appreciate the deflection is compromised to a greater deal. So now it has come to 230, 240-degree deflection. So when the larger caliber laser fiber is in, the deflection is compromised. So when you operate into a lower calyx, that time it's a good idea to use a 200 micron laser fiber rather than using a larger micron laser fiber. Similarly, for the basket, if you put a 1.9 French basket, that's my favorite, you can have almost 270 or 260-degree deflection. So there is no compromise in the deflection. But when you put a 2.4 French basket, you can see it here, the deflection is 230 to 240. So deflection is again hampered. So this is also very, very important, that what accessory to choose when the stone is located in a lower calyx. This is to just you give an idea that the location of an accessory channel in a scope. Every scope has a different location. So Karl Storz has got FlexX 2S, which has got a accessory channel at 9 o'clock position because the fiber is coming out at a 9 o'clock position. But for the digital scope in Karl Storz FlexX C, the accessory channel is at 3 o'clock position. For Olympus, both flexible as well as the digital scope, the accessory comes out at 3 o'clock position. For the Wolf BOA digital scope, it comes out at a 9 o'clock position. While in LithoView and U scope, the disposable scope, the accessory channel is at 3 o'clock position. Is it important to know what difference does it make, whether it is coming out at 9 o'clock or 3 o'clock? It certainly makes a difference. and Dr. Trexler explained it beautifully, that if you are doing a surgery in a left kidney, and if the stone is located in the posterior calyx, that time, if the laser fiber comes out at a 9 o'clock position, it is good. If you are operating on the right side and the stone is located in the anterior calyx, again, if the fiber comes out at 9 o'clock position, it is good. But if you are operating in a left kidney, a right kidney with a posterior calycial stone, if the fiber is coming at 3 o'clock position, it directly hit the stone. So it is very important for you to know which scope you want to use it. And it is very easy to know by evaluating the IVU before going in. So if you evaluate the IVU, that time you will know that the stone is in the anterior calyx or posterior calyx. Depending on that, if you've got possibility to use a different scope, it will make your life easy. Now, the most commonly asked question is whether you need to use a low power laser or a high power laser. In my experience, I can say that most of the stones can be tackled using a 30 to 35 watt low power laser. There is no need for you to use a high power laser if you want to restrict the use of the laser machine only to the stone. If you want to use it for the prostate surgery, or if you want to do popcorning kind of a thing, I think high power laser will be much better, but it is expensive. Secondly, most of the people ask me whether you would like to dust the stone or fragment the stone. So I'll say it all depends on the size of the stone. First, in my practice, if the size of the stone is less than 8 mm in size, in that case, what I do is to fragment the stone in 3, 4, 5 pieces and take out all the stone fragments and do a complete clearance. If the stone is larger than 8 to 9 mm, in that case, what I do is that initially I try to dust the stone, convert a larger stone into a small stone, and then fragment it, and then take out all the fragments. And those fragments can be sent for the stone analysis as well as a stone culture if you wish. So you can produce a complete clearance. If the stone is very large, in that case, you can reduce it to the larger stone to a small stone, and then you can do fragmentation and a popcorning also. So this is a lithoscope from Quanta. It's a 35 watt laser which I use, and this is a holmium laser, 120 watt from Luminous, which is used mainly for the Moses technology. And for the prostate surgery, it's an expensive machine, but very good machine. And this is the third question which is asked is whether you want to go for a holmium laser or thulium laser. Now, thulium is a new blue-eyed boy at the corner of the street sitting there, and all of us are ready to adopt that technology, but the results are not yet out. Initial results are comparatively very good. And tomorrow I'm going to have installation of this thulium fiber machine by Quanta for the first time in India as well as in the entire Southeast Asia. So I'll use it and I'll share my experience later on when I come back to you next time. Let's have a look at the cavity of the laser, the holmium laser. So holmium, in the center, there is a holmium glazing medium docked with the yak crystal, and there are two mirrors. There is a highly refractive mirror and the partial refractive mirror. And if you look at here, this is a real live laser machine. Here you can see there is Nd:YAG crystal in this glazing medium. Here is the flash lamp. So the energy is excited by this flash lamp, and because it is excited by the flash lamp, lot of heat is generated. And to produce a cooling, this is the water cooling devices, and that is the reason that for the holmium laser they are little more bulkier than now recently available thulium fiber laser, because they need a cooling device, and this is one cavity. So in a low power laser there is only one cavity. In a high power laser there are multiple cavities. So you will need a cooling device or inbuilt refrigerator system. This is a thulium fiber laser. Here you can see the energy is excited by these diodes, and there is a fiber. This is a very long, 30-meter long fiber, which is doped with the thulium beads. And these beads are excited, and the energy, laser energy, is produced, and which can be released from this outlet. And this laser fiber is connected to this outlet. So this is a new technology. Here there is a possibility to decrease energy to 0.01 joule, and frequency you can exceed up to 2000. So it is possible to produce a very, very fine dust with this at a very great speed. So let's see, the time will only tell whether the thulium fiber laser will replace holmium or not. But at this moment, holmium laser is still the gold standard. Now let's see what happens once the laser energy is emitted from the fiber tip. This is the scope. This is a laser fiber coming out. The moment optical energy is liberated from the tip of the fiber, and as you know that for the holmium laser to be effective, water is essential. So there is a lot of water irrigation going on around this laser optical energy. The majority of the energy is absorbed by the water, and that forms the water bubble. And so most of the energy is lost into it. The bubble which is formed by this holmium YAG laser, what we use, is a small size. So before it bursts, some amount of the energy passes through that vapor channel and goes to the target, that is the stone. So there is great energy loss. Secondly, the bubble which forms, they burst and they produce acoustic. So this photoacoustic effect can also push the stone slightly back. So there is a retropulsion, but this photoacoustic effect is comparatively less. So mainly the fragmentation or dusting of the stone occurs because of the absorption of this heat on the surface of the stone. That is a photothermal effect, and that will produce a small crevices in the stone, as well as there is some water droplets within the crevices. They will absorb the energy and they again expand, and then they burst. When they burst, they produce a further fragmentation or dusting. So that's how mainly it is a photothermal effect which is responsible for the fragmentation or a dusting. Second is a photoacoustic effect, which has got a very less contribution for the lithotripsy. And then finally, it is a photochemical, which is very, very minimum. This effect is known as a Moses effect, which was described in year 1984. If you look at the laser fiber now, in the center of the laser fiber, there is a glass. Around the glass, there is so that glass will transmit the energy through the internal reflection. Over the glass, there is a cladding. That cladding has a low refraction, and that will help transmission of the energy through the core. And then there is an outer jacket. That is blue color jacket, what you know. It will protect the glass and it will make the laser fiber visible. So when you talk about a 200 micron laser fiber, actual size of the fiber is 374 micron, because when you say 200 micron, you are talking about only the core. So if you consider the cladding as well as the jacket, ultimately the fiber size goes up. Similarly, for 275 micron, it would be somewhere around 450 to 500 micron. Whenever a laser fiber is supplied to you, there is you can see that glass fiber. So they are all stripped fibers. And for the stripping also, the company supplies this stripper. In my practice, we do not strip the fiber. We cut it flash, either with the ceramic scissor or a metallic scissor. Ceramic scissor is usually supplied by the company. It doesn't make any difference whether you use a ceramic fiber, a ceramic scissor or a metallic scissor. You can cut it with anything. It should cut straight. That is most important. So you cannot, when I use it, I cannot see this glass fiber because this is distracting. Sometimes you cannot see it. It's so transparent. Sometimes you cannot see. And secondly, there is a laser light which is coming out through it. I always keep it at a very low. The pilot is set at 1. So there is a minimum and laser light seen falling on the stone. So it will not distract my vision. And it has been studied by Dr. Drexler, and they have suggested that the coated fiber yielded better lithotripsy performance, maybe with the stripping cladding layer may be damaged. That's why you don't need to strip the fiber. Once you use the laser fiber for 15 to 20 minutes, Dr. Drexler always suggests to cut the tip of the laser fiber with this ceramic or a metallic scissor during the surgery for up to 5 mm, 6 mm, the fiber should be cut. Now, what fiber you will select? When you are doing a flexible ureteroscopy for upper calyceal stone or a middle calyceal stone, you may use 270 micron fiber. But when you are performing the RIRS in a lower calyx, please use 200 micron fiber. Similarly, when you are using a semi-rigid ureteroscopy with a 4.5 French scope, you can use 200 micron. When you are using a larger caliber semi-rigid ureteroscope, like 6 French or 8 French, then in that case, you can use a larger fiber like 270 or 365 micron fiber. Now, what precaution you will take when you are inserting a laser fiber in an accessory channel? The first important thing is that you have to select a proper size laser fiber, 200 micron or 270 micron fiber, depending on the site of the stone. Second important thing is that whenever you are inserting a laser fiber, the tip of the scope should be straight like this. If the tip of the scope is flexed like this, and if you insert the laser fiber like this, it will break the accessory channel and your scope is gone. So always make sure that the tip of the scope is straight. Now, how do you make sure? First, check the deflection lever of the scope. The deflection lever of the scope should be in the neutral position. That is one. But after several use, that deflection lever also is compromised. So don't trust only on that. Always tell your assistant to give you a CAM image of the scope before introducing the laser fiber. Check the tip of the scope, it should be straight, and then you can insert the laser fiber. Supposing you don't want to use a CAM, in that case, if you are using a ureteral access sheath, what you can do is that withdraw your ureteroscope into the ureteral access sheath and then insert a laser fiber under vision, so that you don't have to use a CAM. You can avoid using a CAM, and then you have to introduce your scope with the laser fiber into the kidney, and then you can produce a deflection. Now, how much laser fiber should protrude outside the tip of the ureteroscope? Whether it should be this much or it should be less. So this is another study which was conducted by Dr. Drexler in his group, and they suggested that when only 1 centimeter of the laser fiber protrudes through the tip of the ureteroscope, there will be a dusting as well as the fragmentation of the stone, and that will hit the optical lens over at the tip of the scope, and that will damage. So don't keep a distance of only 1 mm. If you keep a distance of 2 mm, there will be some dust that will be hitting the scope. So they suggested that it's safe to keep a distance of 3 mm and do a fragmentation of the stone. So the laser fiber, the stone fragments as well as dust is unlikely to damage the tip of the scope. So this is saying here that, and this laser fiber tip should occupy 1/4 of the, how do you know that it is 3 mm or 2 mm or 1 mm? So it is suggested that it should occupy 1/4 of the screen. Now here you can see it is 1 mm out. So it is occupying almost the very less part of the screen. Now here you can see this is too much outside because it is occupying 1/3 of the screen. You can divide it into 3 parts, this entire screen into 3 parts. But here it is 1/4. So that's a correct method. So that's why if it occupies 1/4 of the screen, it means that it's about 3 mm outside, and then you are safe to do a procedure. So when you now actually reach to the stone, 3 results can be achieved. Either you can do a fragmentation like this, or you can do a dusting like this. And dust is a dust. You can see it, that is like a sand. And each particle is less than 200 micron in size. So you don't have to retrieve this. These are the fragments which are about 3 mm in size that you can deliver through the ureter access sheath. And this is popcorning. Popcorning means that you are keeping the laser fiber away from the stone fragments. So you are not heating the stone and creating a whirlpool kind of a effect like this. So that will colloid the stone and produce a fragmentation with the collision as well as delivery of the laser energy through at the tip of the scope. So you can produce this kind of a nice fragmentation which is less than 1 mm in size. That also does not, you don't need to take out, it will come out on its own. Now let us then what is the utility of a high power laser? Luminous has patented a MOSIS technology. So what is, and from where does this name derive? The name the Moses derived from ancient sage Moses, who parted the Red Sea for his disciple to escape the attack from the enemies. You can see that there is a parting of the Red Sea, and all the disciples passed through this, and then they were saved from the enemies. So that's how the Moses name has come up, and you can see that what we produce in MOSIS is a pulse modulation. So instead of, when your optical energy is liberated, instead of one pulse, there will be two pulses in succession. The first pulse is of a low magnitude, which will be used for formation of a vapor. And it's immediate, at the same time, the second pulse is liberated and it will pass through the vapor tunnel of that bubble, and it will reach to the stone. So the effective delivery of the energy will happen. So instead of one bubble, there are the one pulse, there are two pulses in succession with the MOSIS technology. Here you can see it, that this is a normal formation of a bubble. Here you can see the one bubble is formed and there is another bubble is formed. So these are the two pulses, and that will go to, that will reach to the stone. So instead of one pulse, there are two pulses with the MOSIS technology. Similarly, Quanta also has come out with the same technology, which is known as a virtual basket. In virtual basket also, instead of one pulse, there are two pulses are formed, and here you can see this is a normal pulse. The one bubble is formed. Here the one bubble was formed, and immediately the pulse was, the energy was liberated and it could reach to the stone. So this is a virtual basket technology from Quanta. Now you have initiated the laser machine. The machine does not start. What to do? So there is no output. It means there is the blast shield is faulty. So this is a blast shield which is located in your machine between the laser outlet and a connector for the laser fiber. So whenever there is a laser energy which comes back to the laser machine because of the faulty fiber or a dust over the fiber, it will damage the mirrors. So in order to prevent the damage to the mirror, this glass shield is kept in between. So that will, this kind of a shock absorber system. So blast shield needs to be changed in case if you don't have any output. If there is a very low output, the mirrors are faulty. And if the machine shows you temperature error, you need to change the water. It is recommended that you read the manual, and according to the manual, you replace the water. But every 6 months, it needs to be replaced, especially in a fulmium laser. Now, what type of stones you deal with the RIRS? So normally RIRS is performed when the stone size is less than 2 centimeter in size, especially in the upper calyx and middle calyx, according to the EAU guideline. In my practice, I do up to 2.5 centimeter size stone anywhere in the kidney. So this is an X-ray. Here you can see that this stone is suitable for RIRS, while this stone is suitable for the standard TCNL. But what will you do in such a case where you've got multiple stones? Would you put this many punctures in the kidney to deliver this stone? Or you will do RIRS, where you can see here, this is a real life case. You can see that there are stones in each and every calyx. So with one go, with one procedure, without making any cut in the body, you can retrieve all the stones. So it is very, very important method of dealing with this kind of a situation. Sometimes there is a stone in a cross ectopia with a fusion, or in an ectopic kidney like this, where PCNL should be done sometimes with the laparoscopy guided. You want to avoid it, RIRS is a better option, especially when the stone size is less than 2.5 centimeter in size. Horseshoe kidney with the stone, again a very challenging situation. Here in this case, this patient had a stone in the isthmus. So I did RIRS for this patient. You can see there is a deflection of the scope going into the isthmus. We reached to the stone and we delivered the stone into the kidney, and then in the upper calyx, and then we fragmented the stone. Similarly, a mal-rotated kidney, and these are all challenging cases. To do PCNL is possible, but it is not without any complications. So in such a case, RIRS can come to your rescue. Many a times patients are on blood thinner. Can you do PCNL or ASW in such cases? No. So in such case also, with the blood thinner on, sometimes you can do RIRS. When a patient like this, when a patient is very obese, that time, because of the comorbidity with the obesity, the risk of the surgery increases significantly. So I'll prefer to do RIRS in such patient. Now you have decided to do a surgery. Let's look at the surgery. This is how we normally position our setup. The surgeon is standing. This is the foot end of the patient, and this is the head end of the patient. You can stand like this, facing slightly on the right side. Your neck and your body should be in the same axis so that there is no twisting here. The monitor should be at the eye level. The monitor is placed on the right side of the surgeon. So this is my right side, and the monitor is placed at the eye level. Here is the monitor for the C-arm, and the C-arm is placed on the left side of the surgeon. The laser machine again is placed on the right side of the surgeon, and so the laser fiber comes out here. I'm a right-handed surgeon, so the laser, there is no twisting of the laser fiber also. And the trolley is placed here, and the part of the trolley goes underneath the patient's leg. So the when surgeon wants to take any instrument by himself, he can directly take the instrument without help of an assistant or without twisting the body. So these are all features of ergonomics. You want to stand and do the procedure, or you want to sit the procedure, it's your choice. But you are comfortable doing this procedure in a standing position. But when the stone is when the stone is very large, in that case, I sit and perform the procedure. When the stone is in the lower calyx, it is sometimes very difficult because you have to keep your deflection lever down, and your hand is also not in a comfortable position while you are sitting. So most of the patients, I stand and do the procedure, but you are the boss. You can decide what you want to do. You can see my assistant is quite away from my body. Now, how to hold the scope? That is also very, very important. There are two types of grips advocated. One is a palm grip, where you are holding the scope like this. This is the front end and this is the back end of the grip. You can see that. And here, the entire palm is used to hold the scope. But in that case, it is difficult to do the movement at the wrist, and you are tired. That's why I suggest the finger palm grip. This is also suggested by Dr. Trexler, where almost 2/3 of the scope is gripped by the fingers, and only the 1/3 is done by the palm. Here you can see there is a difference in the distance when the deflection lever is in neutral position between the thumb and the scope. Here you can see, appreciate it, where here the space is very less. This is when you will actually do the procedure, you will realize it more. But this, I thought that it is important that how you should grip the stone also, scope, it is also very important. So now, when you do RIRS, basically you do 4 movements, 2 movements with the left hand, going in and out. You can see that I'm pushing my scope in. Secondly, you can do a twisting movement with your hand. So you can twist the tip of the scope. With the twisting, it is said that you can achieve at least 20 to 30 degrees of the deflection of the tip. Now, with the left hand, what you do is a deflection up and with the right hand, what you can do is a deflection up and down. Here you can see I'm producing a deflection down and I'm looking at the monitor. So this is one movement, and the most important movement is the deflect palm in and palm out movement. So this is palm in and palm out. All the movement should happen at the wrist level. So don't do the movement at the shoulder level. This is mainly when you want to visualize the stone in the middle calyx, because as we know that, look at this. This is a right kidney, the upper calyx, middle calyx, and the lower calyx. The scope comes out through this. This is the pelvis part. Now the tip has to deflect like this. So when you want to go like this, you have to rotate your wrist on the opposite side. So it is said that when you want to produce a palm out movement, the tip will be deflected in. When you are doing a palm in movement, the tip will be deflected out, like in the left kidney. So this is palm out, where your palm is facing out. This is a neutral position, and this is palm in. You can see the scope position of the scope. So when you do this, at that time, here, when you want to look it into the right kidney, you are producing this palm out. When you are doing surgery in the left kidney, because the calyx will come from the lateral side on both the sides. So here I'm doing a palm in. You look at the movement, the position of my hand. So these are the 4 basic movements you are doing during RIRS. 2 with the left hand, going in and out, and the twisting movement. And second, with the right hand, you are doing a deflection up and down, and palm in and palm out movement as described by Dr. Trexler for your entry for deflecting the tip of the scope. The 5th movement, which you can appreciate, this is a patient's movement, not your movement. When the patient is under anesthesia, the kidney moves a lot. So when you keep your scope at the pelvis of the renal pelvis, the stone will come down, the kidney will come down, and the stone will come near to the scope. So that movement also you can use it when you are really operating.
Preferably all the flexible ureteroscopies.
Here I'm demonstrating a case. Here the patient is lying in a lithotomy position, and preferably all the scope surgeries are done under general anesthesia. Why general anesthesia? Because you want a respiration under your control. Your anesthesiologist plays a significant role, because when the patient is breathing, at that time, sometimes with the inspiration, the kidney comes down. So what they do is that they produce a period of hypoventilation or apnea during the surgery, so that the kidney is stabilized, the stone does not move much, and then your job is easy. In this COVID time, we have done many cases under spinal anesthesia. We have our own technique, but I think I don't have the time to describe it. But it is possible to do the surgery under spinal anesthesia also. But preferably, it should be done under general anesthesia, so the respiration is under your 100% control. Here, just to give you an example, this is the general anesthesia with the normal breathing. You can see the stone is moving because the kidney is moving, and sometimes it is difficult when the stone is small to pinpoint the laser fiber at the stone. Here, with the period of hypoventilation, you can see the tidal volume was reduced, and you can see the stone is almost stabilized, and it is possible to produce a very, very precise dusting without damaging the pelvic lysis system. So your anesthesiologist also plays a significant role. Now, RIRS procedure. Normally, when you do the procedure, the first step is to do a cystoscopy. So this is 23 French cystoscopy sheet, and this is a telescope. Normally, I do not do cystoscopy in majority of my patients. My first step is to do a semi-rigid uteroscopy. I use a guide wire, which has got a floppy tip and a rigid shaft. Right? You can use a Terumo guide wire, but my preference is use sensor guide wire from Boston Scientific, because the shaft is stiff. So that will allow backloading of the ureteral access sheath. Also, backloading of the ureteroscope, my flexible scope. So my first step is to do a semi-rigid ureteroscopy in all patients, because I want to avoid a larger caliber instrument in patient's urethra. That's why I omit the step of cystoscopy. But you can, when you are learning, you must do it first to insert the guide wire. So this is my first step. I do 4.5 French. I use a 4.5 French short ureteroscope from the Wolf, and I think it's a lifesaver instrument. The moment you insert the scope in the bladder, what you see is this. On your personal experience, you can categorize ureteric orifice into a small, medium, and large. And when it's a small ureteric orifice, on your judgment, you will know that probably it will be difficult for you to insert a ureteral access sheath in this patient. So you may be required to use a balloon dilator or a Teflon dilator to dilate the UVJ, or you may put the double gestant and come out and go next time. When it is a medium-sized ureteric orifice like this, that time it is possible that you will be in a position to put a 9.5 French or 10 French ureteral access sheath. And if you put a larger ureteric orifice like this, in that case, it is possible to put even a larger sheath. So this usually you get after the producing with the balloon dilation, or if the patient was pre-stented. Now, once you start doing a ureteroscopy and pushing the guide wire in, it is very, very important. You have to be very careful that ureter does not enter into the bladder in a straight course. It takes a curved course. So on the right side, ureteric orifice, the ureteric lumen is between the 9 o'clock and 10 o'clock position. And on the left side, it is between 1 o'clock and 3 o'clock position. So when you try to push a guide wire, sometimes you create a false passage on the right side, somewhere between the 3 o'clock and 9 o'clock position. So I think that is important for you to know. Now, the another step which I normally do is double lumen, use a double lumen ureteric catheter. Before you use it, now the moment the guide wire is in, you always try to fix the guide wire with the jacket here. Now many people don't do this step, and they put the jacket here. So there is a long course for the guide wire to travel, and sometimes the guide wire will slip out of the system. So I always fix it here, and then once I do this job, I use a double lumen ureteric catheter. So this is not a mandatory step. This is a double lumen ureteric catheter. It is a 2 lumen, that's why it is known as double lumen. The tip is 6 French in the diameter. The shaft is 10 French in the diameter, and the length is 45 centimeter. It serves 3 purposes. One, you can insert an additional guide wire through this. So if you believe in putting a safety guide wire, it can help you. Secondly, you can inject the dye through this. So you can do a dye study, because some of the institute, they do a dye study before they do RIRS. And thirdly, it will dilate the ureter. So these are the 3 purposes you achieve by putting a double lumen ureteric catheter. You always backload this double lumen ureteric catheter under the CM guidance. So whatever accessory you put into the ureter, you do under CM guidance, but try to use minimum of radiation, right? So this is double lumen ureteric catheter going in, and then you observe it on CM like this. You can see that double lumen ureteric catheter is going up. So this step is not mandatory, still many people do it. There was a very important article by Dr. Clement about the use of safety guide wire. In my practice, I don't use the safety guide wire, but I don't recommend it. According to EAU and AUA guideline, it is better to use a safety guide wire. It's better to be safe than sorry. But in our experience, we have seen that it's very difficult to retain both the safety guide wire as well as ureteral access sheath in Indian ureters who are not pre-stented. So I don't use it, but you may use it. This is a dye study which is done by injecting the contrast into the double lumen ureteric catheter. So that can give you an idea about the pelvic alysis system. Another step, what I normally do after double lumen ureteric catheter is a placement of the ureteral access sheath. Some people do not put ureteral access sheath, but I prefer to put ureteral access sheath as far as possible. Majority of the patients, I put ureteral access sheath. It has got two part, outer part and the inner part. And this is a Rocomed ureteral access sheath, which is 10 by 12 French in diameter. And it has got the inner part has got two lumen, so you can insert a guide wire through it or insert a dye through it. Whenever you insert this ureteral access sheath in patient's ureter, it is necessary that you lubricate it with the water, because the outer part of this ureteral access sheath as well as the inner part has a hydrophilic coating. So this is you can put some water into it and you can lubricate it. So you don't have to use the jelly for it. So many people use jelly over the ureteral access sheath, but it is not essential. But this lubrication is gone after first use. So if you are reusing the ureteral access sheath, this step is not much of importance. So when you backload now the ureteral access sheath over the guide wire, you can see the guide wire is fixed here. It has not slipped out of the system. You don't have to push the ureteral access sheath. If you feel a resistance anywhere, please stop. Do not go further. Okay. So now here I am backloading the ureteral access sheath. You can see it. The guide wire should not slip out of the system. Your assistant has to help you here. And again, it has to be placed under the C-arm guidance. So here you can see that the ureteral access is going in. And usually the tip of the outer sheath, you can see that I'm just pushing it with the finger. It should be so smooth to go in. You cannot push this ureteral access sheath. This is very, very important. Now, if you put the ureteral access sheath for a very long time in the ureter, there will be a transient ischemia. And this, because of the transient ischemia, once you remove the ureteral access sheath after maybe 1 hour of its usage, there will be reperfusion of the ureter with the blood, and that will bring a lot of oxygen-free radicals, as well as it will produce a subsequent new necrotizing tumor factors, and then it will produce a tissue damage. So postoperatively, stricture formation can happen if you are using a very large size ureteral access sheath for a very long time, because the diameter of the ureter is about 10 French. It is very different at different places, but overall diameter is 10 French. It is safer to put a ureteral access sheath which is 10 French in caliber. So this is the ureteral access sheath, the outer part, the inner part. And if you look at the ureteral access sheath, the outer part, it has got 3 layers. The inner layer, it's a very papery thin layer. Then in the center, there is a reinforcing spring coils, which will prevent the kinking of the ureteral access sheath when you are inserting the ureteral access sheath in the ureter. And there is an outer part, which is a hydrophilic coating. Whenever you put the ureteral access sheath, always put the ureteral access sheath 3 to 4 centimeters below UPJ. That will allow the deflection of the scope into the kidney, especially in the lower calyx, because you can see this bluish marking over the scope from where the deflection happens. If your ureteral access sheath is above this, the deflection will not be achieved. In a female patient, in our Indian population, we use 35 centimeter ureteral access sheath, 35 centimeter long. And in male patients, either you can use 35 centimeter, or if the patient is very tall, in that case, you can use 45 centimeter long ureteral access sheath. So once you put the ureteral access sheath, because the ureter is not straight, you will hit the anterior wall of the ureter. You can see like this. So the trick is that you withdraw the ureteral access sheath, deflect the tip of the ureteroscope, and then go in. So this is also very, very important part. Now you can see here, this is the inner lumen of the ureteral access sheath. This is 9.5 by 11.5 French ureteral access sheath. This is 10, 12, 11, 13, and 12, 14. These are the 4 type of ureteral access, 4 size of ureteral access sheath normally we use. Now, whenever you use a ureteral access sheath, it is important that there has to be adequate water return. It is not important that the water goes in, but it doesn't come out. So there has to be a difference of at least 2 French between the diameter of the flexible scope and the inner diameter of the ureteral access sheath, inner sheath. So this is just to give you idea. These are the different scopes which I use, and this is with the empty channel. Now, if you look at this FlexX-C scope from Karl Storz and look in 10 French, there is this much of space between the scope and the inner part. If you use the 11 French access sheath, the gap is more. And if you use a 12 French ureter access sheath, the gap is very much. But the only problem with using a larger size ureter access sheath is, one, it is difficult to place in a virgin ureter, as well as it is traumatic if you escape for a very long time. So advantages of ureter access sheath: it will facilitate frequent passage of the ureter into the pelvic alyssal system, ureter scope into the pelvic alyssal system. It will decrease the intrapelvic pressure, thereby decreases the risk of infection. Whenever normal intrapelvic pressure is between 0 to 10 millimeter of mercury, if the pressure exceeds beyond 30, in that case, pylovenous and pylolymphatic backflows will happen, and that will lead to absorption of the bacteria and possibility of a bacteremia and sepsis. So it is important that you keep the intrapelvic pressure low at a physiological level with the use of ureter access sheath. Ureter access sheath also will decrease the wear and tear of the scope, and there is a superior drainage is established because of the ureter access sheath. The vision is clear, so retrieval of the stone fragment is also possible, and it will decrease the operation theater time. What are the concerns with the ureter access sheath? That it will induce sometimes trauma and the stricture. Sometimes there is difficulty in insertion and cost. This was an endoscopic classification by Dr. Olivier Trexler. He has graded the injury by undervision inspection of the ureter with the digital scope after finishing every RIRS, and he has graded into 4 grades. Grade 0 means no injury. Grade 1 is injury only to the mucosa. Grade 2 is injury to the mucosa and the muscle. Grade 3 is injury to the mucosa, muscle, and you can see even a perforation. And grade 4, there is a total ureteric avulsion. And in his experience, when they used a 12-14 ureter access sheath, mucosal injury was in about 33% cases. The injury to the muscle was in 10% cases, and there was a perforation in 4% cases. But now this study has no much relevance because we are not using 12-14 ureter access sheath. And they suggested that if you put a double J stent in this patient pre-operatively, it means pre-stenting, then the incidence of injury is comparatively less. This is just to show you our complication where a patient had a stenosis, complete stenosis of the ureter following RIRS, and I could not even pass a guide wire through this. So this patient required open surgery, and this is the injury to the ureter. This is a grade 2 injury up to the muscle. So take-home message for the ureter access sheath: it should be used with the fluoro guidance, proper selection of the ureter access sheath. Pre-stenting always helps. You have to use a small carryable ureter access sheath, mainly 10 French, 10 by 12, that will accommodate both fiber optic scope as well as the digital scope. If you use a safety guide wire, it is good. You remove the ureter access sheath under vision, and post-procedure drainage with the double J stent or a ureteric catheter should be established. And ureter access sheath is not mandatory in every case. Now, once your ureter access sheath is placed, you can backload your ureteroscope over the guide wire like this. So this is my ureteroscope going in, and you can now see the ureter. So many times I have been asked that when you got a ureter access sheath is in position, why do you need to backload this ureteroscope over the guide wire? This is a common question asked. The only explanation is that, as I said, the ureter access sheath, the tip of the ureter access sheath is placed in the upper ureter. So there is a significant difference, there is a significant distance between the pelvis and the ureter, almost of 5 centimeter or 4 centimeter, that if you have a guide wire, you can directly backload the ureteroscope right into the kidney. And if you don't have a guide wire, In that case, you have to traverse that much of the distance without a guide wire. And if the patient has a kink in that upper ureter, you will make your life difficult. So that's why I always recommend to backload the ureteroscope if you have got a guide wire in position. Just to give you about the, I think this will be of interest to the postgraduates. You can see it, the duct of Bellini here, and there is a stone popping out through that duct of Bellini. So this is also a very, very important picture. I think with the digital scope, it is possible to define everything. Similarly, you can see the Rendel's plaque in a stone former. Now, what type of irrigation you use? Normally, we recommend a gravity irrigation, like we connect the IV set with the pint and with the intermittent pressure with the syringe. Some people use a manual pressure device like this. Please do not use this. This will increase significantly intrapelvic pressure. Sometimes the pressure goes above 300. So don't use it. Automatic pressure pump also you can use, but there is no control on the pressure. Peditrol foot control device, it is again a good device, but expensive and not available in India. Traxor flow, this is the good device where you can control the irrigation, and with this pump, you can push the fluid as and when required, but push it with very gently. This is a single action pump device from Boston Scientific. This is again a good device, but little expensive. So what we use is just an extension tube, which normally anesthesiologists use, a 150 centimeter long extension tube with 220 ml syringe, and very gently my assistant will push the fluid. He does not have to push it very hard, otherwise it will raise the intrapelvic pressure very high. So now when you actually do the procedure, you know that any laser has got three important parameters: pulse energy, pulse frequency, and pulse duration. And now you have possibility to modulate the vapor bubble. That's a pulse modulation. So now what parameters one should use when he is doing a procedure? So now here, look here, I'm inserting the laser fiber. This is the 2He adapter, one must know about it. This will allow the laser fiber to go through the accessory channel, a laser fiber or a basket, and then you can fix the laser fiber. So there is no water leak. Now you are seeing the stone, and you can start dusting the stone. Here the energy setting, initially I start with when I want to produce a dusting, I use a painting technique with the laser setting of 0.4 and joule and frequency of 12 to 15. And then gradually, if you've got a high power laser, you can increase the frequency. The frequency will increase the speed of the procedure. That will not help into the dusting. It will increase the speed of the procedure. When you want to produce a dust, the energy should be low, frequency should be high, and the pulse duration should be long. When you want to produce a fragmentation, in that case, energy should be high. That is a 1 joule or 0.7 joule to 0.8 joule, and frequency should be between 10 to 15, and pulse duration should be a short duration. So this you can see that I'm trying to reduce a larger stone into a smaller stone by doing a painting technique. You can see the size of the stone dust. It's very, very, very minute. And once you can produce this, you can also do a chipping technique. While I'm chipping the stone from the periphery, this you can do when the stone is not adherent to the calycial mucosa. Here the mucosa, the stone is free here, so I am doing a chipping technique. Here the size of the fragment is less than 1 millimeter. So that also you don't have to take out. So the idea is to chase a large stone, only one stone, don't fragment the stone, convert it into a very small stone. Once the stone is reduced into a small size, in that case, you can do a fragmentation and take out the stone fragments for the stone analysis as well as stone culture. Once you are done with the procedure, you can do the complete, this is access sheath in the upper ureter, and you can inspect the entire pelvic calyceal system. So you just see that whether the stone fragment has not migrated into any calyx. This is a very mandatory step. Some people check it with the help of a C-arm, but that's not not necessary. And you do the under vision removal of the ureteral access sheath. So that's how you can finish the entire procedure. So, and then we always do a dye study before we take out the scope, just to see whether there is any leak in the pelvic LSL system or not. So if here you can see that there is no leak, it means that we have not raised intrapelvic pressure significantly, and then you can do a placement of the double J stent. When there is a stone in the lower calyx, the idea is to lift the stone from the lower calyx, put it into the upper calyx or a middle calyx, and produce a dusting or a fragmentation. But if the stone is like in this case, you can see that the stone is in the lower calyx. So you can lift the stone with the basket, and here you can see that stone is being lifted and the operator is putting into the upper calyx. Similarly, you can lift another stone and you can place it here and deal with it. Sometimes you don't want to use a basket. What I do is that I can puncture the stone with the laser fiber, and then I lift the stone with the help of the laser fiber and my deflection lever and put it into the upper calyx. This is a risky maneuver, please don't do it. Now, sometimes you
enter the inner lining of a deflected
calyx, it is very difficult to reach to this calyx with the laser fiber in. Here you can see that the stone, the tip is straightened. Now laser fiber is inserted. Now, if you want to reach to the stone, it is not possible to go in. In that case, you can use a ball tip laser fiber. The tip is a ball tip where the scope is deflected and you can still insert the laser fiber. So not necessary to straighten the tip. But the only disadvantage of this is that the laser, this ball tip lasts only for 1 minute. And then that ball tip is destroyed. So after that, you can use this laser fiber as a regular laser fiber. But then when the scope tip is bent, you can use that. You cannot use that laser fiber because the tip is sharp. So you have to be very careful. But you can keep this laser fiber as a reserve. Now, just to tell you a few important points. Here, you can see that once you do a dye study, the vision in the kidney is not that great because the density of the dye is different than the density of the water. So this is what is a vision, but maybe after 1 minute, the same kidney will appear like this. So just wait. Do not start procedure immediately. Now here you can see this is upper calyx, this is middle calyx, and this is a lower calyx. Now, just to demonstrate, the scope is in the pelvis. If I want to go into the upper calyx, then what I have to do is use my left hand and push the scope in. So I can reach into the upper calyx. Here I'm not producing a deflection or very little deflection. I'm coming out through that upper calyx. Now I have to go into this middle calyx. In that case, because I have to rotate the tip this way, I have to rotate my hand on the opposite side. So that is a palm in. So now with that, my tip is deflected and I can see the middle calyx. And if I want to go into the lower calyx here, I have to produce a deflection because the lower calyx is here. I have to produce a deflection and do this procedure. Finally, is it possible to predict that what type of stone it is? Whether it is a calcium oxalate stone, monohydrate, calcium oxalate monohydrate, dihydrate, or a matrix stone, just by the vision. If you have got a digital scope, it is possible to do that. Here you can see that this is a calcium oxalate monohydrate stone, very hard stone. This is calcium oxalate dihydrate stone, where I am in a position to produce a very, very nice dusting. And finally, it is a matrix stone, which is difficult to break because the proper dusting is not possible in this. So here you can see that dusting technique I will be demonstrating. Calcium oxalate, you can see the fine dust here with this stone, and here is the fragmentation with this stone. If you have got a very tight ureter, what will you do? If you have got a very tight ureter like this, my advice will be put a stent and come out and go next time. Don't try to push your ureteroscope through this, otherwise you will damage the ureteric mucosa. And if you have got turbid urine like this, when you are doing a procedure, you can see there is a lot of turbidity inside. And that time, I think if you have just started the procedure, put a stent and come out, go next time. Always make sure that when you do RIRS, patient's urine culture should be negative. That's the most important aspect. And this will prevent a lot of infection. There are many causes of infection. The first cause is that patient's urine culture, if positive, patient will have post-operative bacteremia or septicemia. Another cause of infection is that patient-related factor, where patient has got low immunity or a diabetes, or if it is an infected stone. In that case, also patient is likely to have a post-operatively bacteremia or septicemia. And third important thing is the sterilization-related complications of infection. If the scope is put into the side X, or if not properly washed, in that case, chances of infection increases. In my hospital, we do a plasma sterilization for every scope. So our infection rate is almost in the range of 6%. And in all patients, we go pre-operatively, we give one shot. Intraoperatively, as well as post-op, we get one more shot. And then patient is discharged with the oral antibiotic in majority of my patients. Only 3 or 4 patients out of 100 develop post-operative fever, which require intravenous antibiotics for 5 days. Patient is discharged with advice to take the IV antibiotics at home. Finally, I will touch upon the radiation part. Radiation is very, very important. You are young people, so take care of it, because you should be, when many people do a lot of PCNL, they are exposed to a lot of radiation. With RIRS, our attempt is to reduce a minimum radiation. In my hospital, our radiation time for every procedure is about 6 seconds. So this you can achieve. There are surgeons, patients, as well as the staff. All three are affected by radiation. The patient is affected maximum because patient has to undergo pre-operatively investigation, where you go for CT scan or X-rays. During the surgery, radiation due to the IITV, and post-operatively for the follow-up. While in case of surgeon can also get exposed during the surgery, and especially he uses CM for the localization of the stone, for the insertion of the accessory in the ureter, when he does the dye study, to identify the complex pelvic alyssal system, and for the placement of double gestation. So both surgeon and staff are exposed to it. So you have to try to limit radiation. For localization of the stone, in my practice, I hardly need to use a CM. For insertion of accessories, yes, it should be guided, but it should be single shot when you are doing a procedure. Dye study, we are not doing routinely. We are doing dye study only post-operatively, and that time, once the kidney is filled up with the dye under the flexible ureteroscopic guided, that time only we give only one shot and put a double stent in a desired position, and we also check for the dye leak. So that's where we are using radiation. We are using minimum radiation, and there are many things we can cover, but I think I tried to cover as many things I could cover. Most important thing is that your laser control should be so good, and I think you can achieve it 100% with some experience, and you should be able to write your name on the stone. That should be the laser control, and that's the message I want to give you, friends. Learning RIRS is easy if you are trained properly, but you have to understand this procedure correctly. Then you can make your life and your patient's life easy. Thank you so much. Dr. Hota, I am done with my presentation. And if there are any questions, I'll be happy to take.
Thank you, Dr. Parikh. It was a wonderful talk. In fact, as you mentioned, this is very basic talk you have given. Everything's detailedly threadbare, mentioned by you. In fact, many things which normally we do not find in the workshop and seminars. You have gone into every aspect of it. So nice talk from your side. I find that good participation is there, and one of the participants is Dr. C.S. Ratkal. Dr. Ratkal, can you unmute your video also? If I am audible to Dr. Ratkal, he is a very senior urologist from Bangalore. Dr. Ratkal, am I audible? Anyway, I think when he unmutes, by that time, all the participants, they're, welcome for any queries. I was looking at the chat box. I think so nicely described this, the RIRS procedure, starting from the basics. There possibly not many questions were there, but however, we have unmuted all. They themselves can unmute and interact with Dr. Parikh as and when they feel like. Dr. Rajendra Punjabi, I think you seem to give some observation.
Good evening, sir. Good evening, everybody. And very, very nice to see the presentation of Kandarv. It was really great. He, as you said, he presented every minute thing also. And it is really great to see all of you. And you have arranged such a nice telemedicine, and you have got such a good telemedicine center. And nice to see all of you. Congratulations. I hope all of you are keeping well.
All the residents, they are very eagerly, they have been listening to the talk by Dr. Parikh. What is the specialty of Dr. Parikh? Each word is punctuated.
Yes.
Meant for that, each word, and he finished very much within 1.5 hours. That is also another, mastery that you have. One question came from one of our ex-residents who is a consultant in Hyderabad, Dr. Rakesh Panda. What is the most important factor of prevention of post-RIS fever? I think you have partly covered it, but you would like to reiterate further. Dr. Rakesh Panda, you can also unmute yourself and can interact. Dr. Rakesh Panda is working in Priti Urology at Hyderabad. Rakesh, are you there? Unmute question, sir.
Parikh sir, please unmute. Actually,
yes, sir. Good evening, sir.
Good evening, Rakesh. I think let me introduce. He passed out a 1.5 years back from us.
Okay, so Rakesh, nice to hear from you, and give my regards to my friend Chandra Mohan. I think you are working there, and
Yes,
I had an opportunity to operate at his hospital 2 times during UCCon, as well as one of the workshop he conducted last time, and it was a pleasure operating there. And answering to your question regarding the infection, I covered, and I have classified infection post-RIRS into 3 groups, but 3 reasons for it. One is a patient-related reason, where the patient is immunocompromised, patient is diabetic, culture is positive, patient has an infected stone. So this could be one reason why patient develop infection. Second important thing is that when you are operating, and even if the culture was negative, that time if there is a lot of turbidity inside, and we tend to forget that we tend to do the surgery in such patients. I think probably it is better that we abandon the procedure and do it next time. Secondly, the surgeon should be very, very careful regarding the intrapelvic pressure. So your assistant, whosoever is irrigating the system, has to irrigate it very, very gently. Sometimes during the workshop also, in order to get a good vision, sometimes we tell our assistant to irrigate the fluid with a lot of pressure, but post-operatively, ultimately patient develops fever. So that is surgeon-related thing. And the third important thing is a sterilization-related factor, which is responsible for the infection. So you have to sterilize it with either ETO or a plasma sterilization. I think probably, or sometimes you can use a disposable scope. The incidence of infection will go down. But I can understand that everybody cannot have plasma sterilization. Everybody cannot afford to have a disposable scope. So in that case, you cover the patient with proper antibiotic, but make sure that the urine culture is negative and intrapelvic pressure is less. I think if these 2 factors, if you consider, probably you will save lot many patients with with post-operative infection. Because in my practice, when I learned RIRS to begin with, many patients, the only problem which I faced was post-op infection, fever, and all that thing. But believe me, right now in last few years, our results, which we have already published in some of the journals also, are almost matching international standard, and we give antibiotics only on the day of admission, and the day of discharge. The patient is kept in the hospital for 24 hours. So after that, we give only a single, we give oral antibiotic, that to a very, very low grade antibiotic, kind of a ciprofloxacin or something. So and also in my hospital, we take stone culture in most of my patients. So even if the urine culture is negative, we take all the, most of the patients, we take a sample for the stone culture as well as stone analysis. And if the stone culture comes positive, and even if the urine culture is negative, we put the patient on antibiotic according to the sensitivity.
Thank you, Dr. Parikh. I think there is a small extension on what Dr. Rakesh Panda has already mentioned. You possibly you do not give a stent post-operatively because you are dusting so finely 1 millimeter, 2 millimeter. Do you routinely give a stent?
Yeah, it all depends on it all depends on the size of the stone and the kind of dusting I have produced. But if it is a large stone, and if I have taken a lot of time in the ureter, and if I have placed the ureteral extract, certainly I would love to put double J stent and drain the cysting. You know, there is a saying for double J stent that if you put if you put a double J stent, you suffer. If you don't put a double J stent, you suffer. If you put a double J stent, patient suffers, and then you suffer. And if you don't put a double J stent, patient suffer and you suffer a lot, because then you have to come to the hospital middle of the night. So I think double J stent, I think probably I would like to put in majority of my patients, except the stone was very small and I have not put a ureteral extract.
Thank you. One more, I think Dr. Vinit Sakiredi. You can unmute Dr. Sakiredi. He has asked a question. In fact, I have a query on that. During your talk, you had mentioned about not to strip, but to cut. So therefore, I think he has a point, very, very nice point, because we are very used to doing a stripping, you know. That is what routine practice go for stripping. But as you rightly said, the pilot light is also a problem. If you strip little more, the pilot light is also a big problem. You know, it takes up the region of the stone. It makes a glaring effect. So, you know, do you feel that if you don't strip, the laser energy that is delivered to the stone, there is a reduction in the laser energy?
There is no reason for it. This is the amount of energy which is delivered to the stone remains same even if you strip or you don't strip. Only disadvantage of stripping, which in my mind, I think probably it is not even mentioned in the literature, whatever I have read up till now. See, you don't strip and you still keep on firing. So what happens inside, sometimes you don't know. Sometimes there may be some cracks within that glass fiber, glass laser fiber within that jacket, blue jacket, that you don't know. And sometimes then instead of laser energy being emitted at the tip, it will come out through that particular crack, and that might damage your scope. Or secondly, it may not deliver the adequate energy. That is the reason Dr. Trexler has suggested that after every 15 minutes or 20 minutes, you cut the laser fiber from the tip. About 5 to 7, he suggested 1 centimeter, but I do about 5 to 7 mm after 15-20 minutes. So then there is an efficient energy delivery at the tip.
Okay, Dr. Binit, anything you would like to ask further than what we have discussed?
That's it, sir. Thank you, sir.
Dr. Binit, anything else you would like to ask?
That's it, sir. Thank you, sir. Thank you very much, sir.
I think there is a question. I think compliments are more than the questions. That is what the peculiarity here. Dr. Jayant Kanskar has mentioned the wonderful basic points explained in detail, and he has expressed his thanks. And few questions. You know, how do you measure intrapelvic pressures to keep it optimum? What is your experience about thermal injury with laser fragmentation? This name has not come. I think the gentleman had surfaced some time back. He has only mentioned about it in mobile, I think.
Okay. So actually, there is no method available at this moment for measuring the intrapelvic pressure while you are operating. It is, but there are some papers where they have tried to measure the intrapelvic pressure by putting a ureteric catheter, which is connected to a pressure transducer by the side of the scope. So, they have measured the pressure, and they have suggested that when you push a lot of pressure, either with the help of a pressure pump or with the help of a handheld device, that time the pressure will exceed 200 to 300. And that is the reason it is recommended that you use a gravity irrigation where the IV point is kept at the level 40 centimeter above the chest level. So In that case, probably the intrapelvic pressure which is maintained while you are operating will be at the physiological level. And when you push fluid with little bit of pressure in order to clear the vision while you are operating, that time slightly there will be raise in the pressure which is above 40. But when you put a ureteral access sheath, it is said that it reduces the intrapelvic pressure by 50%. So that is the purpose of putting a ureteral access sheath, and that's the reason I like it. Many people who are using ureteral access, many people are against ureteral access sheath because it produces a trauma. Now, in my experience, let me tell you that in last few years, I have hardly seen any case, except for one case which I demonstrated. I have not seen any case of ureteric stricture following placement of the ureteral access sheath. Patient develop ureteric stricture following ureteral access sheath because of few reasons. First, improper selection of the size. If it is 12, 14 or 14, 16, I have seen somebody putting even a 14, 16. You are not putting, you are actually pushing. Don't push, just glide it. If you should glide, the ureteral access sheath doesn't go, put a double stent and come out, no problem. Or you just simply backload your ureteroscope over the guide wire, which will walk in, and then you can finish the job and maybe put a stent later on. I mean, that after you finish the procedure. So that is one reason. Secondly, if the ureteral access sheath lies for a very long time, that's the reason I curtail my operating time to 90 minutes. My lasing time is usually about 40 to 50 minutes. My overall surgical procedure time, right from the patient in to out, is about 90 minutes. So if I don't exceed my operating time, don't keep the ureteral access sheath for a very long time, this is less likely to produce trauma. And the third important thing is that reduce the size caliber of the ureteral access sheath. That's the reason 10 by 12 French ureteral access sheath serves a good purpose, and it will not produce much trauma. And because I'm in a private practice, I can afford to use a new ureteral access sheath in every patient. So this is very well lubricated ureteral access sheath, and I'm happy that my stricture rate is very, very low. In India, I have seen, in fact, I also used to do, I put the ureteral access sheath in order to sterilize it. We used to put it in a Sidex. Now, Sidex has an acidic nature. So when you take out that ureteral access sheath, is completely banned, and it becomes very brittle. And that lubricating layer is also gone after first use. So these are the reasons why patient develop ureteral access sheath induced injury. So I believe that 10, 12 will be a good compromise. And recently we are doing one study using a 10, 12 ureteral access sheath. And our study is for 40 patients, where we want to see whether we could put a new ureteral access sheath in how many unstented patients, and what was the follow-up after 6 months or so, that what was the status of the kidney and the ureter, whether the patient developed hydronephrosis, hydroureter because of the ureteral access sheath induced injury or not.
Thank you, Dr. Parikh. I think Dr. Robin Joshi want to ask some questions. Can you unmute Dr. Joshi?
Thank you, sir. I'm from Nepal. I think
Unmute your video also.
Hi, Robin. How are you?
fine, sir. I'm calling from mobile. That's why my video is not so good.
Okay.
Anyway, so because my center has MCS resident, the presentation has gone very well, and we have been doing RIRS for past 2 years. Just started 2 years, and the presentation has gone very well. My query is the left hand and the right hand, because we are very used to with the right hand only. Is it always necessary to change your hand one, or left or right? And do you always do dusting or you do fragmentation during RIRS?
Okay, so I think the second part of your question I already answered, that in majority of my patients, I look at the size of the stone and what is the philosophy of treating this patient. Supposing if the stone size is less than 8 mm in size, in that case, what I prefer to do is just simply fragment the stone in 4 or 5 pieces. And as I told you that majority of patients, I put a ureteral access sheath. So I just simply fragment and take out the stone and do a complete clearance. If the stone is larger than 8 mm or 9 mm, or if the patient's stone bulk is more, even if the stone is 9 mm or 10 mm, in that case, what I do is that I try to do a dusting from the periphery to the center. Don't break the stone to begin with. convert that large stone into a small stone, chasing only one stone by producing a very nice dust. And it is very, very easy to produce a fine dusting of the periphery. The moment you go into the center, because the stone size is also reduced, patient is also, there is a respiratory movement. Sometimes it is very difficult to produce that kind of fine dusting. And the stone center is also very hard. In that case, I fragment and then I take out the pieces. So sometimes I do both dusting as well as fragmentation. And in a small stone, I do fragmentation and take out the stone. So that is question number one, sorry, the part two of your question. And regarding changing the hand, I'm a right-handed surgeon, so probably I'll be more comfortable operating the patient with the right hand, and left hand is to support the scope which is coming out through the ureteral access sheath. If somebody is lefty, in that case, he has to do the procedure because he'll be more comfortable with the left hand. So, but during the procedure, you don't need to change it. And believe me, if you do a proper selection of the cases, no case will go on more than 30 to 40 minutes when the stone is less than 1 to 1.5 centimeter in size. If the stone is larger than 2.5 centimeter, in that case only the time exceeds to 90 minutes. I think many of people who are in the audience, because I can see how many people are there, but those who are in the audience, some of them, I mean, I have heard their name and I know them personally. So they have come to my center for the RIRS training program, and we demonstrate 5 cases during that program. We start with a very small size stone to the very last stone in an anatomical abnormal kidney. That's the last case. And we can produce equally good result. But the time factor also one has to keep in mind. We don't exceed more than 90 minutes. I think that is, I'm very, very rigid about it. Of course, sometimes if it becomes 95, doesn't matter. But the point is that you try to curtail your operating time also.
Yeah, Dr. Parikh, there is a very delicate and sensitive question.
Okay.
I think Dr. Abdul Salam will put it to you directly. Dr. Abdul Salam.
Thank you very much. Thank you.
Yes, yes.
Dr. Abdul Salam.
Yes, sir. Am I audible?
Yes,
yeah,
yes.
Please put your sensitive questions.
I am from Bangladesh.
I will
I
answer
am
in
from
this
Bangladesh.
We'll see.
Yes, sir.
Yeah.
What is the cost of every cases? Say this is 15 millimeter of stone. What is the cost? As you said, only 50 to 60 cases can be done average by a video scope or a digital scope. So cost is the factor here. So what is your actually average cost of each patient?
Before I answer this sensitive question, I hope that you are not planning to refer me a patient actually. So no problem. But just to answer your question, I said that my majority of my scope, and I think in many of your hands, I mean, many of the people who are doing RIRS regularly, their scope lasts between 50 to 60 cases. That's a minimum. And then if it requires a repair, go for a repair and replacement. So then it will, the next scope which you are going to get, it is a very low cost. Once you break the scope, they will not replace it. They will ask you for a new scope. Similarly, for the digital scope, my digital scope lasts between somewhere, the last scope, I mean, almost every scope lasts between 70 to 80 or 90 cases. My scope lasts little lesser than probably some of my friends who are doing RIRS regularly. The reason, I don't know the reason, but what I feel is that I do not want to compromise my result with a compromised deflection. So I go for a replacement if the deflection of my scope is not proper. Even if the scope vision is hardly affected actually. So vision is good, but the deflection is not proper. I will not like to compromise my result because I'll tell you what I'm charging, and then you will know about it. So I go for a replacement, and I get a replacement at a little lower cost than majority of people, because I've been using RIRS for a very long time from one particular company also. So they are also supporting a lot. And secondly, regarding the charges, the charges depend on city to city. Every city has a different charges. When in fact, I have received some patients from Bangladesh also after I conducted my course in Bangladesh. And usually in India, we are charging, I mean, Ahmedabad, sorry, no, I can say India, but Ahmedabad, it will be somewhere around 90,000 rupees as a total package cost, because it's my own hospital. If I operate in a corporate hospital, it goes up. But it is my own hospital where we use everything, good quality stuff, still my take-home money is good, no problem. It would be at least 30,000-40,000 after every case. So I think I'm happy with that. And it starts with 90,000 and it goes up to 1.5 lakh rupees depending upon the class of the patient. Starting from the semi room to the suite room. So that's what we charge. So RIRS, I tell you, because many people discuss only about the cost about it. But the another advantage which I have seen is that once you master into one particular technique, you get a reference from many places, from your country or from outside the country also. And if you are forced to do it in your city, I think probably you will have edge on others. In my practice, I have been referred patients from many places in India and adjoining nations. And every monthly I get a patient from one of our, and it's a urologist who is referring the patient. So he's preparing the patient, he's telling patient everything about pros and cons, and he's also, updating about the chart structure also. So your job is easy. So ultimately, in a long run, it really helps you. And the most important thing which I feel is that after RIRS, majority of patients, I'm extremely relaxed. I can go for even immediately after I finish my surgery, if I have to go and attend some family function or go travel also outside the country or city, I can do it because I know that by and large nothing is going to happen to this patient. But if you do PCNL and mini PCNL, sometimes, I'm not that expert into mini PCNL and PCNL, but sometimes I have my worries that I cannot leave my place immediate after operating such patient.
Thank you, Dr. Parikh. One query I have, in fact, during the discussion initially you had mentioned that up to 3 centimeter you are going for RIRS, 3 centimeter stone. And do you take into consideration the composition of stone as regard the size is concerned, like calcium oxalate, monohydrate, 3 centimeter stone, because of the duration that you may consume while doing a RIRS and the stone clearance? These are the two factors, duration.
Okay. So I never said that, unfortunately, I never said that I am doing it up to 3 centimeter. I said that the next EU guideline which will come, which will probably tell us that you can do RIRS up to 3 centimeter in size. In my practice also, preferentially, I do RIRS for 2 centimeter size anywhere in the kidney. I don't say that it is a lower calaceal stone, so I don't do RIRS for less than. That's what I said, that up to 2 centimeter, I'm very comfortable, or even 2.5 centimeter. That's the maximum I do. And in fact, what has happened that majority of the patients referred to me or coming to me only come to me because I do RIRS and they don't want to go for a PCNL. So even if the size of the stone is 2.5 centimeter, we explain them everything that I may require to go in again second time if the stone is very large and, as you said, very hard stone or a very large stone burden. Probably a patient is ready, but patients do not want a puncture. And especially, I'm telling you, when the patient is a high risk patient is affluent class, when the patient is a solitary kidney or anatomical abnormal kidney, even if you operate 2.5 centimeter size stone, they would not mind to undergo second or third look of surgery, but they don't want a puncture because solitary kidney, if you do PCNL and if you end up in trouble, I think it's a very, very big price the patient is paying. So we explain to the patient. I understand your question very well. And so that's why you have to explain the procedure as well as pros and cons of each to all patients so that your life is easy. Otherwise, it will make your life miserable after the surgery.
Yeah, I mean, I think the natural sequelae of the question next is that if it is a stone which is less than 1 centimeter, not that radio dense, and you have done a CT scan, the Hansford unit is around 600, 700. Now, less than 1 centimeter, very ideally located upper calyceal or pelvic stone. How do you counsel a patient when you give them the option of ESWL and the RIRS?
Frankly speaking, less than 1 centimeter, with whether it's a radiolucent or a radio opaque stone, my first preference would be ESWL. The reason that is my first preference, and I give it to my patient. I do not do RIRS for 6 mm or 7 mm stone unless the stones are multiple in number, unless patient wants a complete clearance at first go, because there are some patients, as you know, they are working into some government institute or merchant navy or pilots. I have operated many pilots also. So they want a complete clearance at one go. Lithotripsy you cannot guarantee. Second important thing is that when the patient is coming from outstation, like we get a lot of patients from in Ahmedabad, from Rajasthan, Madhya Pradesh. So in that case, if I do lithotripsy and if the patient has got a residual fragments or the stone come down into the ureter, when the patient go back to his native place and if he ends up in trouble, what will he do? So that time we tell the patient that naturally the first option would be ESWL, but we have to offer a custom-made treatment option to the patient, considering all these factors. Otherwise, as you said, 600 HU patient or whatever HU you said, 600, 700 HU and 1 centimeter stone in upper calyx or a pelvis, even if it is a not a very radio dense stone, you can do a sonographic location. We have got a facility and you can do a sonographic location and then you can bang the stone. But then you have to tell the patient that if the fragments come down into the ureter and you go back to Rajasthan, then probably you'll have to consult your nearby doctors. And most of the times, patient coming from Rajasthan, Madhya Pradesh, they unfortunately, once they have come to Ahmedabad, they want a complete clearance at one go. Naturally, they have come for the treatment. So they will say that, okay, no, doctor, you do RIRS, give me a complete clearance at one go. And 1 centimeter, naturally, we will be, by and large, we'll be in a position to give him a complete clearance.
I think this is a beautiful discussion we had. Many more questions might be there. Anybody from the participant, if they want to speak directly to Dr. Parikh, you can always do it. You can unmute and ask questions. Before we conclude, I have a few more things to mention also. Anybody else from SCV? There's so many. I mean, I'm coming to you a later part of the time. I have already realized when I'll come to you. Now, any participant from SCV? So many people are eagerly listening to the talk. Amit, Vishwajit, you would like to ask any questions? Yeah, unmute. I think let my residents also know little more than what they wanted to know. Rakesh, your third question is not answered as yet. Would you like to ask?
Thank you very much, sir. The presentation was very nice. We learned a lot of things from your presentation, sir. My question is, sir, for beginners, what kind of instrument we have to buy at the starting?
So if you have to buy only one scope, I will recommend that you buy a fiber optic flexible scope from whatever company you get a good deal and good backup. That is my recommendation for the scope. For the laser, I think you can buy 35 watt laser of whatever company. Again, I'm using a Quanta laser because, and I'm very happy because in last 4 years, there is not a single time there is a laser failure. So that's why I'm happy with that laser, because I have conducted many workshops across the country and outside the country. But some of the, there are some occasions where when you are actually at the stone and we are demonstrating, at that time the laser machine fails after maybe 4 to 5 minutes usage. So with this machine, I'm happy. So I'm using 35 watt, but whatever company you want to buy, you can buy, no problem. And but don't compromise on the accessories. Most important that you start doing RIRS only keeping only one access sheet in your armamentarium or only one basket or one guide wire. Please don't do it. You invest in my hospital. I'm also keeping a very good stock of all the accessories, so that in case if I'm stuck up somewhere, I can use. I don't have to run around. And these accessories are not available in a regular medical store. That's another problem. So at least you should have at least 2-3 baskets in your armamentarium, 2-3 ureteral access sheets of different size. And I think this laser and flexible fiber optic flexible scope. And please try to understand that the components of the scope. That's why I spend a little more time on my explanation of the different part of the scope, which is very, very important. And these pictures I have taken myself personally. We have opened the scope and we have taken all the pictures personally. This is just to explain you guys that these are the components, and if you understand these components, you exactly know what to take, how much deflection you should produce, how will you break the fiber scope, and ultimately it costs a lot. I broke my first scope on 11th case when I started the program, my RIRS in my hospital in 2008. So, and that time it really created a big pocket, a big hole in my pocket. So I think when people, but you should not face this. That's the reason I said that this kind of teaching has a value.
If any other question from any of the participants, otherwise I'll hand over to Dr. Samir Shai. And before I hand over, any question from any participant?
I would like to ask, sir, one more thing, sir. Yes, sir. What would you advise to freelancers to sterilization of the scope, sir? How they will sterilize fiber optic scope, sir?
I don't know how freelancers are going to get an access to the laser also. So
sir, they actually in small cities they are just taking on hire the lasers, sir. But that sterilization procedure, few of my friends they have this query.
I tell you frankly, some people are using Parasafe instead of using a Sidex. I think that is much safer. The most important thing is that you have to completely clean your scope. So after you use, immerse it completely in the water, flush the channel. Sometimes some people forget to flush the channel, but flush the channel will also have a lot of blood and debris inside. So you have to completely flush the channel with the syringe very gently. At least 30 ml or 40 ml of water should be pushed in, and then you have to put it into the Sidex and then flush the channel again with the Parasafe, and then flush the channel with the Parasafe also, and again clean it with the sterile water or sterile water, and then you can use it. That's the keep it at least for 20 minutes in your solution. This chemical solution sterilization, now I have stopped doing it, so I don't know much about it. I'm not in a favor of doing it also, because the infection, and I was also tired having infection in my initial practice. But then I thought of, at least you can do ETO. If you can have access in your city of ETO, you can sterilize the scope, so you can at least do one procedure very safely.
Thank you, Rakesh. Any more queries from your side? I think all the three queries that you had are already been answered.
Yes, sir. Yes, sir.
In your chat box, 3 queries. Now,
yes, sir.
Ratkal sir, welcome.
Yeah, good evening, sir. Good evening.
I was looking for you, sir.
I was hiding. Now I want to give a comment. That is, Kandar.
Yes, sir.
This thulium 3060 is portable laser.
Yes, sir.
Which I have. Many times people take from me also and do their procedure. Okay. 60 is quite good for prostate also. Okay. Just I wanted to give that information. Okay. Thank you.
Yes, sir. I agree that it is a portable laser.
Yeah.
If it is, but I believe that it's a big risk you are taking, giving your machine to be transported to some other hospitals. Though the company people, when they want to sell it, they will always
more aware than me.
This is a portable machine. In fact, I don't have a thulium. Tomorrow they are going to install in my hospital.
I am using it.
So you can because it's a plug and play. It's kind of plug and play.
Very simple that way.
So you can do it.
Only later there may be risk, but RIRS.
I don't want that anybody, if a company people person is coming to your hospital and shifting the machine from one hospital to another, it is good. But if dedicated person is not doing that job, sometimes you will
maybe any portability has some risk.
Big loss. And secondly, it is, even if the moment it is known to the company people that you are using is a portable laser, in that case probably they will not cover you under warranty guarantee also. So I don't know whether it's a very very good idea, but yes, can be done. But the question which was asked to me was regarding flexible uteroscope sterilization.
Yeah,
so,
that I know, but when you raised that doubt, that's why I clarified. No, sterilization is, I do this, what is plasma only. So
yes,
that is really problematic.
And you have been to my place, you know it, that we we do.
So it is always best to practice in one place. That is how when I started my practice, I was moving to 30-35 hospitals in Bangalore. Now I am sitting in one place only. I am very happy and comfortable. Okay, that I agree.
Dr. Atal, thanks a lot. I think we are looking from you.
No, no, Kandarp means I love to hear him because his every time he teaches something new and something good. 100 times if I hear him, still I want to 101 again. I want to attend his because he teaches very nicely, very nicely.
That's so nice of you, sir. In fact, if you are completing our discussion, thanks to Dr.
Only
Parikh.
because I never wanted to come to into your area.
You're always welcome, sir. Always welcome.
I know.
Yeah.
Thank you, thank you.
Few things
Will not refuse me anytime. Okay.
Few things I'd like to mention.
Yeah,
In fact,
thank you.
Urology Academic Forum of Odisha was started in 2015, and
Good.
this Urology Academic Forum of Odisha was mainly meant for this academic activity in the urology fraternity.
You are doing good work.
Yeah, we conducted the national conference in 2019, USI 2019 at Bhubaneswar, and presently at the helm is Dr. Samir Swai. So before I hand over, if he has any queries, he can say and offer a vote of thanks.
Good evening, Dr. Kandap. Good evening, Hota sir, and dear friends. There are a lot of participants with active participation, and there was a beautiful and basic preliminary discussion. What Dr. Kandap Parikh has made is commendable, and I am very well known to him personally, and we are very good, close. But still, as per RIRS, he is unmatched. So I think probably our residents and who are starting RIRS from within a shorter period, or they are newcomer, they must be benefited a lot. And again, regarding few discussion of infection and all, my point of only suggestion is to avoid using reusable things. Second point is to take adequate precaution. Third is to take care of your flexi URS just like a neonate. My point is flexi URS just like neonate because it's a neonate. It has to be handled with care. And special thanks to Dr. Kandap and thanks to Professor Hota to give us such a good platform to have a beautiful discussion and interaction with Dr. Kandap. And on behalf of Urology Academic Forum of Odisha, I thanks all the participants and Dr. Kandap again for this wonderful evening.
I think there is one information I would like to put in. As I mentioned, the Urology Academic Forum will be having regular academic events like this. In the month of January, we are planning for a uro-oncology part of it. We have our website, SCB website is www.scbmch.in. scbmch.in. Whatever academic activity we will conduct through the Urology Academy Forum, it will be available and we'll let everybody know. But we had a wonderful time, Dr. Parikh. I can assure you that we will be hearing you further again for the advanced RIRS. Thanking you all, Dr. Samir. We had a very wonderful program. Dr. Atal, thank you.
Thank you. Pleasure is mine. And thank you again to all the listeners for joining us. And thank you, Dr. Hota and your team for the opportunity to me to interact with mainly many postgraduates and some of the senior colleagues who have joined this program today. And thank you so much. I appreciate your all efforts. And thank you to your team, Dr. Amit and all the friends who have worked hard for this program. Thank you so much. So we can sign off now, sir. Thank you.
Thank you. Thank you so much. Thank you.
Okay. Bye-bye.
Thank you, sir. Thank you.
बढ़िया प्रोग्राम। एटा प्रति 1.5 मास गुड लगा।